to rescue. It's funny. I think he needs no introduction actually. But I will go through it. So, did training medical school in Romania, and then came here to Beth Israel for residency and then cardiology fellowship here at Emory, and then stayed on at faculty and has been a cherished member of our educational community involved in resident education. And then it's great to have you here to speak about this topic, which is diuretics and acutely decompensated heart failure. Thanks for being here.
Thank you, John. It's always a great honor and pleasure to be here. I thought today I'll present more of a method of how to approach the diuretics using heart failure based on the best I could find evidence-based medicine. It's only one really clinical trial that's worth mentioning here, the dose trial. But everything else is more of a physiology kind of data that when I had the chance, I'm going to post it there so one understands how we come across this method. And first of all, why do we need to treat congestions? Why do we need to use the poison, the diuretic, and particularly in patients with heart failure? Is because even the only reason is to prevent patients from coming to the hospital. As a matter of fact, 9% of them come with some version of congestion. Even heart failure may not be the primary cause of why the patient is hospitalized, also primary cause of rehospitalization, as everybody knows. So it's important, even if we don't necessarily improve mortality. Sodium and water retention does contribute to heart failure progression. So we know the patient who stays chronic congested and volume overloaded has heart failure progression. So that which on long term will alter mortality. Really, the medicines that we've proven, at least in patients with systolic heart failure, that work and prolong life, improve survival, improve ejection fraction, they work on patients who are outpatient euvolemic, not necessarily the one who are volume overloaded. As a matter of fact, we have evidence showing that if somebody is volume overloaded, you give them an ACE inhibitor, they only get half of the hemodynamic response and benefits. So keep that in mind. Once you have also right side heart failure, gut congestions, most of the medicines become extremely poor bioavailable. So even if we think, oh, they're great target medicines, it's just not going to do the job. And that's one of the reasons why I have a job. When I see them in clinic, I just admit them, take the 20, 30 pounds fluid overload, put them back on medicines, and voila, 6 months later, the heart function has improved. So that's extremely important. And last but not least, once you have progressive heart failure, we define progressive heart failure. We see it most of the time by a simple variable that we all get. It's the creatinine. It's once they develop renal dysfunction, we know those are advanced heart failure patients. And it doesn't matter if it's just temporary acute kidney injury or it's more permanent. We know that that's actually makes it extremely difficult to actually treat these patients. So, and that's part of neurohormone activation, and volume and persistent volume is actually one of the stimulus for that. So it's extremely important for prognosis on long term for these patients. Now, it's easier said than done using diuretics. Everybody knows nephrologists don't like it because it hurts the kidneys, and all of us, of course, we don't like it when that happens. How do we balance the benefits versus risk of using this? So I'm going to start with a simple question for which I do have now evidence-based medicine to give the answer. If you give a small dose of furosemide, 40 milligrams IV, to a patient who has chronic systolic heart failure, so I'm not talking about acute, this is chronic systolic heart failure with chronic neurohormone activation, and we try to measure invasive hemodynamics for this patient. What is really the effect, the hemodynamics effect of the furosemide IV? Is it going to reduce the cardiac filling pressures and systemic vascular resist? Everything we know is bad for somebody with advanced heart failure, and that's actually the intent of it, right? Is it going to increase it, make it worse? Is it going to have no effect on cardiac hemodynamics? Or, we're going to eventually dry out the patient and cause him hypotensive. And believe it or not, this has been studied. And the purpose why I address this is to relieve some anxiety doctors have that diuretics in patients with chronic heart failure cause hypotension, and they don't. As a matter of fact, the answer is opposite. As a matter of fact, it causes increased systemic vascular resistance. Often the minor arterial pressure will go up after it, will reduce the cardiac output, and that's mostly because actually when you look at the data, and here, the authors that published this, Dr. Gary Francis, over 30 years ago at Cleveland Clinic, shows that indeed, as expected, on baseline, these patients have elevated wedge. They have elevated systemic vascular resistance. They already have prior neurohormone activation. In general, these values should be in the 5 range or less in the renin-angiotensin, while the plasma norepinephrine should really be, if you're at rest, in the 10 or 20 range. These values of plasma norepinephrine of 600 is like you're running a marathon, and these are constant in this patient. So if you give them, and these are patients who mostly have normal kidney function at that time, so an advanced heart failure that doesn't have yet renal dysfunction. And when you give them, within 10 to 20 minutes, all these numbers that we know are bad in acute heart failure, they're just worse. The mean arterial pressure goes up, the systemic vascular resistance goes up, and notice about 50% elevation of this baseline neurohormone activation. And I wanted to make a point with this study because, unfortunately, it's the only study that we have on showing how diuretics in patients with chronic heart failure or acute on chronic hurt the heart and the kidneys. So basically, it's a simple answer. They are directly toxic by activating neurohormones from the kidney. And it's a normal response of the kidney. It doesn't like diuretics. As a matter of fact, the moment you hit with the loop of Hele, blocking that sodium and chloride reabsorption of the loop of Hele causes a rush of sodium and chloride in the distal tubule right next to macula densa that immediately activates a lot of renin production. And that's one of the simple mechanisms we know. So keep that in mind, that each time you use furosemide, you will activate, as a matter of time, more neurohormone activation. So temporarily, you're going to actually aggravate the congestive heart failure. And sometimes you may notice you have patients who are extremely vulnerable below. You give them suddenly a strong dose of diuretic, they will tell you, oh, I felt worse last night. And that's just part of fluid getting mobilized and SVR going up and everything else. And this doesn't happen just acute if you give it. The time course of this IV, 40 only of furosemide, is about 8 hours. So it increases the neurohormone activation by 50% in about 20 minutes, and then it goes back down to normal at 8 hours. Unfortunately, the authors did not do a dose response, which will be extremely useful here, or going beyond the 8 hours time point. But nonetheless, it's an extremely useful study. And then chronically, if this patient is seen as outpatient, came down on chronic loop diuretic, they get the same thing. It's called aldosterone escape. But bottom line is, no matter what, whether it's acute or chronic, diuretics will cause chronic neurohormone activation in these patients, and which is actually the basis of the whole heart failure progression. So, and even if you don't have chronic heart failure, have acute heart failure, and you just give us 80 milligrams dose of furosemide, you do diurese the 1.5 liters, but then GFR drops immediately by 25%, and we know kidney is not going to tolerate that, will activate neurohormone. So acute, chronic, any dose, just know you're going to hurt the kidneys. So I'm stating that there. I know diuretic used in heart failure, and each time we use it, we pick a dose, we have this apprehension that immediately activates our amygdala, the anxiety center, and oh my God, I'm going to go a little gentle on the furosemide. I'm not doing 200 like Sorescu says. I'm going to do 40 or 60. 60, always call it, 60 is the nice doctor kind of dose, because you feel like you need more than 40, but you're afraid to use 80. And it just doesn't make any sense, because actually we have now evidence-based medicine. So I'd like to relax and calm down this anxiety and show you what we really know about this. And what we know about this, everybody knows how to recognize the prenausothermia that's set by diuretics. Is not necessarily dehydration. All right, that can happen. It can cause intravascular depletion, but this actually happens extremely rarely. Only if you put somebody on high-dose diuretics and you're not watching them, you're not examining them every day, knowing when to stop it. And a simple way of testing that is check orthostatics. If they're not orthostatic, if the creatinine got worse because of your furosemide, has nothing to do with intravascular depletion. All right. And so, okay, well, I learned that even before you hit somebody with furosemide, chronic elevated LVDP, activates neurohormones. Do we ever measure these neurohormones? We know they're there, but there is one test we measure that's absolutely quantitative, identical with this, and that's the BNP. So when you see from now on the BNP in the bloodstream, think this is the hemoglobin 1C for diabetes equivalent, but for heart failure. The higher the BNP, the more prolonged of this neurohormone activation, more neurohormones are activated. It doesn't tell you the amount of volume of blood patient, doesn't necessarily correlate with that, although it may, if it's been for, accumulate 30, 40 pounds. It just tells you how long has been poorly controlled. That's all right? And basically, these are the neurohormones you measure. BNP is simple, stimulated by this hormone as a protective reaction by the heart to try to counteract the vasoconstriction that the other hormones do. So we measure it. we measure indirectly the renin-angiotensin. We measure the adrenaline. Just think that's what BNP does, okay? And we know, I can tell it, anybody who goes for heart transplant has got a BNP in the 2,000 to 5,000 range, that we can never get it down, I know. So therefore, I put this because it's very important. It's just slightly different light. We talk about neurohormones, think BNP, all right? And, no matter what we do, these neurohormones do two things that are clinically meaningful for us. They do about thousands of them if you were to read all the literature from basic science. But that's clinically irrelevant. What's really clinically relevant, they either increase the sodium and water reabsorption from the kidney, and it continue to expand the plasma volume and then aggravate more the LVDP, or they increase the vascular resistance, which aggravates eventually cardiac output, more cardiac filling pressure, releases more BNP. So initially, we just have either left-sided heart failure, and LVDP is elevated, or we have right-sided heart failure. That means our pressure is over 20 or RVDP is elevated. It doesn't matter what's the original stimulus. Once you activate these neurohormone activations, it eventually gets there. We have plenty of patients who can have end-stage heart failure from originally just right-side heart failure or end-stage left-side heart failure that leads to the right side. But at the end of the day, that's all that happens. And of course, then once we hit that critical level, what we call pre-renal azotemia, even before patient was diuresed or admitted in the hospital, that means advanced heart failure. That means we know that pretty much the neurohormones are so activated, the kidneys are so, basically it's intending to shut itself down to protect, because it thinks there is not enough intravascular volume. It's a protective mechanism short term, there is a long term. And when we do, we use diuretics and we just bang the kidney. Whether it's with 40 or with 200, you're going to aggravate this. It's just going to make it worse. So this is a summary of what we know before we actually hit with the diuretics. And so I'm going to try to come up with heart failure is chronic neurohormone activation, which is caused by the volume. Diuretics aggravate the neurohormone activation, which is caused by the volume. Then which one it is? How am I going to stay in the middle, try to get the benefits and not the risk from using the diuretics acutely? So here's how I think, and I think this is a method that I'm proposing. I've been using it for 15 years, but it's based on the data we know retrospectively now. Basically, when somebody's got cardiac filling pressures elevated, we're going to have volume up, we're going to have neurohormones that are up. This is heart failure progression. I'm going to start, ideally, we'd like this patient with chronic heart failure to have function here somewhere. Now, when let's say, came with this volume up around 10, 20 pounds fluid overload, I'm going to use 40 IV of furosemide. But that 40 IV of furosemide does not make a meaningful diuretic effect. In other words, it's actually not successful in dropping back to the baseline, the dry weight. Patient came with 20 pounds, I only diuresed 1 pound, I am down to 19. All you do is just get the side effects, okay? And that's why often you see patients still volume overloaded. You use a certain amount of diuretic, they diurese about a liter or so, but they're only minus 200, 300 cc's. You gave the side effects of the diuretic. You made more neurohormone activation. You did not meaningfully achieve the purpose of actually dropping the chronic neurohormone activation, which is part of cardiac volume overload, because we haven't really got the volume down close to what it needs to, so we reduce the cardiac filling pressure. So instead of doing that and keep going that cycle, you'll see me, usually call me, we're around here when creatinine is 3.5. Right, so what do? I go and I examine patient based on volume overload. I might use some minor vasodilators, and bang, I blast the patient with something that's 3-4 times higher dose and say, well, he can do that. All right, but what it is, and I don't do it one day, I don't do it 2 days. I keep going until I'm done, and I think I remove about 80% of the fluid that was above the dry weight, so I achieve that. Why? I want this patient, once I get there, even if it's not perfect, but after that tolerates PO diuretics, I know this patient is more likely, it's not going to come back right away in the hospital with volume overload, number one cause of rehospitalization. All our guidelines how to avoid rehospitalization, by the way, are useless. The same way all research has shown that is useless. Nothing works. No telemetry, no appointment within a week. We want them to see them in a week, but what really matters is actually if we get that volume down and we treat the comorbid illnesses before they leave the hospital. That's what matters. It's not written anywhere. You can't assess it because it's easier to just do some chart review or do stuff that will be paid by somebody, but it's meaningless to actually what matters. The only thing they've shown to work is called heart failure disease management program. I don't know what that means. It means that people who have experience and know the patient well, make sure working with you guys, we keep them immediately in the clinic. I get onto them to cut the sodium intake. We establish a relationship, and we really make that to happen. Even they would be in incomplete diuresis in the hospital. I continue this as outpatient, see them frequently until I win them off in the urovolemic. That's the only thing that's shown, and that's what we do. We actually diurese the patient as outpatient. We actually, go up on the medicine. We don't just stop there, treat other things. So I hope this helps. Acutely, diuretics will worsen the peak part of extra neurohormone activation. Chronically, if you can get them euvolemic, you actually reduce the NPMP. And we have the data showing that whatever you do, the magic in the hospital, if you cut that BMP from whatever was the baseline to half or less, that patient is extremely unlikely they'll come back in the hospital in a month, and they will tolerate the beta blocker ACE inhibitors. And if you cannot do it, either you haven't finished what you started, or the patient has actually true advanced heart failure. Those we would like them to be referred to heart failure clinics so we can see what other options we have for them in terms of advanced heart failure therapy. Either way, it tells us great news, okay? So now, talking about method, easier said than done. I found, this is an article, it publishes a state review article, a state-of-the-art paper in 2008 in Journal of American College of Cardiology, and I really got excited about it. I was actually extremely, happy, because first time when the nephrologist and cardiologist got together, wrote together a paper, the true experts, okay? And they classify actually in a clinical, meaningful way how to deal with this cardiorenal syndrome. What is it, cardiorenal syndrome? Well, they classify in 5 different types. Type 1 and 2 are heart causing the kidney failure. Type 3 and 4, kidney causing the heart failure. So the first 2 are cardiologists. The next 2 are the nephrologists should be in charge of it. And then type 5 is where we often fight over who's going to own the patient, is the systemic illnesses that can cause both. And I would like for you not to forget that really the number 1 cause of acute kidney injury in the ICU and probably in the hospital is not heart failure, is not diuretics, is sepsis. It's inflammation that's systemic enough to affect that. So that's important, okay? Why? Because as a heart failure doctor, not only the kidneys, their job is to keep an eye on the heart. Everything that's wrong with the heart is going to have a consequence on the kidneys. But then the kidneys, I know once they are chronically activated, they're not happy, they're going to cause damage to the heart, lungs, and everything else. So I want the kidneys to be happy, but I need to recognize what else can hurt the kidneys in order for me to be able, after I fix the kidneys, get my volume down and get them out of heart failure. So that's extremely important. All right. And in terms of how exactly heart failure can hurt the kidneys, we have 3 pieces of data. All right. One is any kind of neurohormone activation. It doesn't matter what's the etiology. It doesn't matter what the LV and RV function. You have normal biventricular function. Once you activate the neurohormones, perfect example, sleep apnea. Actually, patients with sleep apnea have adrenaline through the roof at night, and the same with angiotensin. Once you activate those, they do the same thing. They cause, renal vasoconstriction, which is documented in patients with heart failure, and renal vascular resistance with overall reduced renal blood plasma flow, although you may have preserved GFR for a while, meaning they can have that neurohormone activation elevated without creatinine necessarily being abnormal initially, but then you don't know, until you hit them with a diuretic. And that's extremely important. So first stage of any cardiorenal syndrome is actually persistent neurohormone activation for whatever reason that climbs down the kidney, all right? And if you were to measure it clinically, you can look at the BMP. I don't know why the BMP keeps staying up. That's one way, all right? But another way is to look at the BUN, not the creatinine. BUN actually in early stages correlate, creatinine can stay normal, but BUN correlates actually with this progressive neurohormone activation and renal vasoconstriction. What we call pre-renal, even with creatinine 1.1, that would be normal, is actually BUN being high. Pay attention, unless you think patient is dehydrated, got fever, other reasons, or steroids on board. Let's assume there is no other reason. That BUN going up, that's the silence before the storm. It tells you the proximal tubule, it's in a hyperfunction, reabsorbing sodium with the BUN because the loop and heli is not working because the kidney is ischemic at the inner medulla. That's what it's telling you. And you have angiotensin that's activated. So keep an eye on that. It's more creatinine will stay and then bang, just go up whenever it's too late. Okay. And indeed, so one mechanism, once you have neurohormones, you can have perfect normal cardiac output, perfect normal LV and RV function, then you have renal vasoconstriction. The second stage is when you have, or independently, if you have elevated right atrial pressure over 20 millimeters mercury. We have those studies done. It's been done in dogs, in pigs, and in humans. And basically, Anything that suddenly raises the right atrial pressure around 20, which will mean the IJ elevated up to the earlobe, that you see it very clear pulsating there, immediately is going to impair the GFR and will activate the neurohormones. And as a matter of fact, in the heart failure literature, we know that actually, if we were to measure all these fancy hemodynamics as somebody with a progressive heart failure, the single most important predictor of developing acute kidney injury in the hospital, up to 80%, is the CVP. It doesn't matter what's your cardiac output. All right? If your CVP is in that over 24, 80% will develop AKI in the hospital or progressive renal failure. So CVP, pay attention to that. Even if I tell you on a report the LV function is normal, remember the heart also has a right ventricle. If it says B, then visualize where you see patient is getting worse. Call us, we'll look again at the echo. We need to know what's happening with the RV because that's the mystery there. Okay? So heart has two parts, right and left. They both affect the kidney hemodynamics and they can trigger the same neurohormone activation. And this has been published, in, believe it or not, and it's not new. I started to think about this when I completed my fellowship, but already it's been published in 1931. Okay? And with extremely limited methods we used to have back then, they notice people have a lot of volume, they get diuretics, they lose 30 pounds, urine output increases, and the creatinine improves. Okay? So, very well-known fact. All right, so what is cardiorenal syndrome? Worsening renal function in somebody with acute on chronic heart failure, despite the fact that, I get the motivation to stop the diuretic, but I still see a lot of volume board that I think contributes to the symptoms and not well-being of the patient. So that's a cardiorenal syndrome. Volume is up. I still need to diurese. I hit once with diuretics. Kidneys decide to go wrong. Something is not right. So how do we sort that out? Okay. So here's where the problem is. It's easier said than done. I said, well, cardiorenal syndrome is that. And what do you do? All right. We know we got to, that moment, hold in the diuretic if the kidney is getting worse, but we still need to get the volume off. We still need to do something about it. So here's why we run into trouble. Because while it's the clinical definition like that, it's extremely useful if you only deal with heart failure causing the kidney dysfunction. Actually, more often than not, patients who are in the hospital have other reasons why their kidney can get worse, what I call the comorbid illnesses. They have other mechanisms that can confound that cardiorenal syndrome. Basically, it tells the kidney, you shut down, and then the kidney retains the volume, and then if I hit them with diuretics, it's going to make it worse. And sure, heart failure-related reasons, I told you, inappropriate renal vasoconstriction, renal vein hypertension, or congestion, or right atrial pressure over 20, and then diuretic-induced neurohormone activation. Know the diuretics at any dose hurts the kidney. Those are the three. And the last but not least part of heart failure is low cardiac output. This is only in advanced stages, so it's not really a common denominator, contrary to, you see me putting somebody immediately on, creatinine is 3.5, was 1.5, EF is 35%, calls for rescue, kidney getting gotten worse, and he's going to put the patient on the diuretics. And more often than not, I don't, because I can look at the echo, and I know if the heart or the cardiac output is going to justify this. As a matter of fact, we have surrogates now looking at the echo for cardiac output, even if our clinical assessment is not that. We call it VTI, and sometimes you'll see me write in a report, evidence of low cardiac output, VTI is low. And that tells you extra, even if they look warm, and that's for real. So it's not a perfect quantitative assessment, but it tells you it's low for sure. Okay? So those are the main things that we know heart failure per se can cause, of course, kidney dysfunction. And those, of course, you work with us, with cardiologists, and we'll do all kinds of, maybe some vasodilators, maybe some inotropes. But then what do you do with the others? Relative or absolute hypotension. So one hypotensive SVP, so 2 hours with a mean arterial pressure less than 65, it's enough to cause AKI. And typically, you recognize that, but only, or it could be what I call relative hypotension. That means if somebody has chronic diabetes and hypertension, their systolic pressure is to be 170, all right, or 160 as outpatient, and then suddenly their pressure is 110, which we may be comfortable with it, but that kidney is not comfortable because you reset that blood pressure point to function at the lethal level. So you see me often, I go in and I see that diabetic, long-standing hypertension, systolic pressure is 110, and say, oh, we need to, it's hard to hold the house stop to, we got to add some hydrolysis. And I said, no, step back here. This is the patient is too hypotensive what it needs. You see me cutting off everything and then wait for that blood pressure to recover and then try to diurese after I see the urine pick up. So that's one common, denominator. Intravascular depletion from diuretics, of course, this is the most well-known, and I can tell you, I almost don't ever see it on patients on our service, okay? It's extremely, extremely unlikely, okay? Contrary to our perception. And if you're in doubt and you think, well, that's just peripheral edema from venostasis, I get it. Check orthostatics. If the patient orthostatics, you're right, hold the diuretics. It could be also septic or other reasons for orthostatics, but at least we got enough reasons to hold the diuretics. But a patient is not orthostatic. That is not why that patient has acute kidney injury, okay? And we need to dig more, find out what else is going on. Guess what? You can have sepsis, SIRS, gout, UTI, upper respiratory infection, any little flu-like illness. Why? Because these guys, when they release TNF-alpha and IL-6, I'll show you some data, their job is to distribute the blood. It's vasoconstrict the kidney and central organs and vasodilate the periphery. Now, they have not been reported in we went through medical school, all of us. We had to sit for United States medical license. There's never been a question that UTI can cause AKI, right? It's not there. And you know why? Because those are studies, one condition, somebody was healthy, no other issues. We have yet to study those with two conditions or multiple comorbid illnesses. So that does not apply here. And kidney has been injured in the background with chronic neurohormone activation. You hit with diuretic, and also gets the TNF-alpha IL-6 that does the opposite. Those are the kidneys that will be affected by a little gout, a little URI, or anything else, okay? So that's important. Increased abdominal pressure. Anybody who's obese, that by itself, nephrologists, general surgeon have done the study, increasing abdominal pressure can cause that. Obstructive uropathy, a simple thing. Anybody who's older than 65, I check their prostate if they have AKI before I even think about my furosemide. I don't care. I go and ask them, does it go out easily or is it stop and go? It's a stop and go. I'm checking blood or scan, okay? Because that's simple things that you can relieve the obstruction, and suddenly you fix your AKI and you can continue diuresis. So again, it's a plethora, a mixture of mechanisms from other comorbid illnesses that normal if each of those, a little UTI and a little, gout, you can treat as outpatient. And you think, well, that doesn't explain why patient is in the hospital. Yes, it does with somebody with advanced heart failure with other issues going on. Yes, and often it's more than two. And because of all this happening, and because we get cardiorenal syndrome, more often than not, about half of our patients who actually leave the hospital have a weight that is the same or higher than before they got in the hospital. Same their BNP. So we're not doing, fantastic job with that. And, and we're not that we mean to do that, but, first do not harm. I get it why you get excited when you see the furosemide. After using furosemide, creatinine gets worse. But there's something else going on. And I want to remind you that no matter what magic we think the furosemide does to hurt the kidney, there's only one mechanism that we know that they do. Is basically an anti-sodium agent. If there's too much sodium in the body, there's too much water, the water just follows sodium. If you use the antidote, the kidney is going to react to it, eventually trying to prevent the effect. But that's it. It's sodium, anti-sodium, sodium, anti-sodium. So we can do whatever we want to do. But if you give the patient a certain amount of furosemide, somebody's 40 pounds of fluid overload, at the same time you prescribe fluids, normal saline, or you prescribe Zosine, which a dose of 24 hours of Zosine is equivalent of a liter of normal saline, which is equivalent to 9 grams of salt. And for 1 gram of salt, they'll retain 1 pound of water. This is the mechanism how you get that. Or the resident who is on call the night before, potassium dropped to 2.7, and we activate our potassium replacement protocols, right? Well, those come with 40 milliequivalents of potassium in 500 cc's of normal saline, I used to train in other hospitals where we use D5 water. We don't have that anymore. Pharmacy goes with normal saline. So that is the problem. While I'm trying to fix a little potassium with that instead of using PO, which gets absorbed in half an hour, and then you're going to have bounce back volume overload 2 or 3 days later. So those are simple things that we got to do. And I know it sounds ridiculous and simple, but these are the simple things we do that make a difference. So now we're done with the boring stuff. Let's go and see some patients. We're going to go over some case studies and see if it makes a difference, all right? So this is a 67 years old man. He has a chronic systolic heart failure EF of 25%, comes in the hospital with acute heart failure, gained 12 pounds in 4 weeks, has been taking his furosemide 40 every day, run out of medicines, warm and wet, lots of fluid overload, BNP 700, creatinine is 1.6. All right, so what would you do next? And here we're going to talk about the dose of the furosemide. We can do 40 IV, we can do 60, we can do 80, we can do 100, or we can just use late furosemide drip because nephrologists and critical care specialists have some small studies showing that may be protecting for the kidney as opposed to the bolus. And the reason I put this is actually a dose trial that showed us the proper answer for this. All right. So basically, the proper answer is, let's see, we give the dose trial, randomized patients to low dose versus high dose furosemide. In other words, the patient was on 40 PO as outpatient, was converted to 40 IV. It was on 40 PO. A high dose version would be 100 milligrams, 2.5 fold. So it wasn't 40, 60, 80, 100. Okay, it was either 40 or 100. Okay, so and they want to see what's going on. So let's see what this showed. If I were to use 40 or I were to use 100, what benefits according to these studies were? All right. The high dose furosemide is superior to low dose diuretic, improving mortality and hospital admission. And the answer is no. There was no dose that made the difference in terms of mortality. There was no method of giving it, whether it's bolus or drip, that made the difference. And there's absolutely the same. They call it a neutral study. Actually, I thought it was an extremely useful study because, and you'll see if you actually look at the data, low dose furosemide causes less renal dysfunction at 60 days. Is that correct? And the answer is no. While there was some AKI that's caused by the high dose, all right, it's a long term, as long as you don't send them home on that high dose in IV, actually there was no difference in terms of the renal dysfunction later on. Constant IV infusion is superior to bolus. That was not correct. So unfortunately, it took a year. One of the reasons why it took for a year for this study to be published, usually gets published within a week, just so you know. It's because the nephrologists didn't like the results. The critical care guys didn't like the results. It didn't prove the hypothesis. And it's possible they could have proven the hypothesis was a larger number. The study was excellent design, but only 400 patients, each of them 100 in each group. I think we're just not designed to have power to really look at the mortality. The high dose furosemide improved dyspnea score, pro-BNP, and more weight loss than the low dose diuretic, and that is correct. And one could say, well, what's the point? What is the point of doing that if you don't improve mortality? And I say, well, acute heart failure means patients in the hospital. Yes, I think avoiding patient coming in the hospital or getting them out of the hospital, I think it's an important endpoint, even if the only reason is symptoms here. So I think that's important. And there was no difference between the 2 doses of furosemide and total weight loss. That is not true. That is exactly what it does. If you just increase 2.5-fold the dose, you will lose more weight. There's no doubt. That was proven. And you improve the dyspnea score. The catch is, while you're doing all that, you actually do have more AKI, right? So high dose was more effective to reduce symptoms of congestion, weight, and the marker of neurohormone activation that we know, which is the BNP. But you had higher risk of transient acute renal failure or acute kidney injury, as defined, of increase of creatinine of more than 0.3 in over 72 hours. Okay. Now, here's the data, and everybody said, well, okay, so do I really want to take the risk? Because what happens if you increase the AKI? You have to hold the diuretic, right? And then you hold the diuretic, patient will stay longer in the hospital, correct? Well, so here's what we can learn from this, okay? All right. I want to point out that contrary to the perception, when you look, the dose was increased from whatever was 100% to 250%. All right. So we go up 2.5-fold on the dose. But when you look at the risk of AKI, 60% of all AKIs were caused in the low dose. In other words, it doesn't matter what dose you're going to use. No, you're going to hurt the kidneys. There was only, so contrary to our perception, the risk extra 40% out of the total that was increased risk when I actually increased 250% my dose was not linear or exponential correlated, but actually extremely low compared to the baseline, which even a low dose will do it. And by all means, I'm not an advocate, then why bother? Just put everybody on high dose and go home. No, I don't agree with that, because with the low dose, you got patient diuresing in average 6.5 pounds over 3 days. With a high dose, you have a patient in average diuresing 9 and 10 pounds. What I think you need to do is we need to get better in assessing how much volume above the dry weight the patient has. And if they have below 10 pounds, so I have this rule, if it's less than 10 pounds, then I'm going to use the low dose. We'll do just fine. And I want to be on the safe side, not causing AKI and prolonging the hospital admission. If I have more than 10 pounds, then there's no purpose of just doing low dose. We'll never get anywhere, okay? We can use straight high dose because I know my risk-benefit ratio is towards, I might cause a little extra AKI, but at least I'm getting some volume down and get the patient out of the hospital, all right? And that's how we interpret this, okay? In other words, we don't want to go this way with the low dose for somebody who has more than 10 pounds fluid overload. We want to go this way for somebody who has a lot of volume overload, okay? And that's extremely important. So that's a strategy. And we actually know that long-term high-dose diuretics as outpatient are extremely dangerous. It causes AKI and worse mortality. There were 2 studies that were done in Italy. Actually, their plan was to assess, believe it or not, the stated hypothesis was to test whether dietary restriction of sodium is going to improve the outcome in patients with heart failure. And to their surprise, you know, when they did that, the ones who were on more sodium restriction, that means less than 2,300 milligrams, had worse kidney failure and mortality on long term of 6 and 12 months than the ones who were more than 2,300, okay, 3,700. I don't know how they calculated that. Having said that, I was reading that and I said, oh my God, so much for all our, tell the patient to, you know, restrict their sodium for heart failure. This is outpatient study in Italy. And then I look at the dose of the furosemide they're on. Check this out. Between 250 to 500 twice a day. I know. I don't think you need to be a nephrologist to realize this is just insane to do this for 6 to 12 months on a patient. I have no idea how they passed the RRB. And were between up to 2, the other one, there was 12-month study, was up to 250 BID. It's mega doses of furosemide. So no, I would take this as a proof that chronic toxic doses of diuretics on long term are deleterious for heart failure, which we kind of know. But acute short term in the hospital where you check the kidneys every day are okay as long as you meaningfully remove some volume. That's all. That's how I take it. And this was not a sodium restriction study. And I'm ashamed to, you know, that this was actually published in one of our prestigious cardiology journals. But it is what it is. So, and you know, this just shows that indeed the mortality was worse. Guess what? If you use poisonous doses of furosemide, then its antidote, which is sodium, is going to protect the kidneys. It makes sense, all right? And that's what this study shows. So, no, I'm not advocating mega doses of diuretics as outpatient, all right? And if we do that, we do it very briefly for a few days. We check them out in the clinic next week. It's not long-term without supervision, all right? But you see, it's fascinating. We have to do this yin and yang of diuretics. On one hand, they can decrease neurohormone activation if you meaningfully remove the volume. At the same time, they can increase the acute. And what you want to do, the little bumps in acute increase, you want to be overridden long-term by meaningful baseline drop in that, okay, by looking at the BNP. So in conclusion, total daily dose of furosemide, like dose trial, correlates with total urine output, per day. That's it. So if you look at the patient from the door and you can see the edema, then you can feel free to use the high dose, okay? If you go, and particularly right side heart failure, if you have a patient who you have to really look hard to find the volume, they're just short of breath, probably you can try a low dose provided there are no other issues going on, renal dysfunction or some other issues, okay? And it's very simple, all right? And I recommend, based on the study, a goal-directed approach, just like nephrology do on dialysis. Let's try to get good at estimating how much was above the dry weight. Let's just find this simple cutoff of 10 pounds to be safe. If it's more than 10 pounds, I'm going to use the high dose. If it's less than 10 pounds, I can use the low dose or whatever you want. I personally think you can use any dose as long as next day you don't put it standing. Next day you check the kidney function, says the volume status, and see what was the response. Okay, because if you stop it, it goes away. So, all right. So volume of heart failure is difficult to recognize, particularly patients who are obese. Everybody has this hard time, not just me. Causes worse in-patient mortality and morbidity, and is associated with high rehospitalization rates. It's important to get somebody with volume because that's how, when they benefit from everything we know helps systolic heart failure, and we know that it's difficult to treat once patient has renal dysfunction. All right, and basically my recommendation based on the dose trials and method is let's get good at estimating how much volume patient has above the dry weight. All right, now that's easier said than done, right? Because if you look at our daily weights in the hospital, it could be 10 or 20 pounds difference from one day to another. If you look at you can compare patient scale from home with the scale that we have. Often patients who've been educated about this, they actually can tell you, I gain about 10 pounds, but most of them not. And also if it's chronic congestion, that means chronic right side heart failure, actually you can have stable weight over long term, but you lose your dry mass and you make it up with fluid. So actually symptoms of the patient will be more reliable. So the last 15 years, they developed a simple method of how, try to guesstimate that or try to semi-quantify that. I found it useful, particular people I trained. It's easy to pick that up. At least it gives us a big bulk of an idea. And basically, you take everything into account: the JVP, the lung sounds, the heart sounds, abdomen. If they have any evidence of ascites, elevated BNP doesn't necessarily correlate again with the amount, correlates with the chronicity of it. Like hemoglobin A1C will correlate with the chronicity of diabetes. You have diabetes that's just 200 for 6 months, they can still have a hemoglobin A1C of 14 if there hasn't been control. And as opposed to one that has 400, then it could be only 7.5. Okay, so and now the trick with chronic heart failure as opposed to acute is that the volume starts to hide, particularly the lung and the abdomen part, because you mobilize. If it's chronic, you increase the lymphatics in the lung about 10 times, and fluid moves out of alveoli. So you're not going to see on X-ray the usual highlight pattern of butterfly white. You're not. All you can see in X-ray usually will be curly B, lines. Which, when was the last time you guys read that on a radiology report? I mean, I was a student last time I've seen that. All right, and you're not gonna. Those are the lymphatics, by the way, I'm talking about. Okay, and then. But there's another way that, and I encourage you, look yourself at the X-ray, because unfortunately radiologists have kind of lost the skill to read the X-rays. They're very good at reading the CAT scans. Look at yourself. If you see even small pleural effusion, I know you tend to, it's just a small pleural effusion. Well, in somebody with chronic heart failure, that tells you that the lung parenchymal capacity has been exceeded, and now you're pouring the fluid in the pleural space. That's advanced heart failure. That means you have at least probably 5 to 10 pounds just in the lungs, depending how big is the person. All right, so it's real, even if it's a little, okay, if it's chronic. The most, and the patient may not tell you much, unless you move them around. And they're in rest, they'll tell you they're okay, and they learn to do less and less. So you can't really trust the patient too much unless you kind of sort, okay, what were you doing a year ago? Shopping a Walmart. What do you now? I'm mostly in the heart. Maybe I'll go to the mailbox in the house. Well, that tells you something has happened, and then I'll take that little pleural effusion there, all right, with the BNP that's elevated. All right, so believe it or not, in chronic heart failure, the most reliable way to detect the volume overload is actually not so much the physical exam, unless you get lucky and you have tremendous right-side heart failure, is actually patient symptoms, but you got to learn objectively how to quantify that. Early satiety, JVP up to the earlobe, patients having to sleep up or they have anxiety attacks, they wake up in the middle of the night. That's their PND equivalent, but you got to learn how to sort that out. And I developed this simple vertical classification of edema, okay? So instead of doing, I realize our medical textbooks, unfortunately, have not, and our clinical skills have fallen behind the computers and lab skills, so to speak, okay? Really, that classification, 1+, if it goes like this, 4+ goes all the way and stays there, it's just useless. I don't know why we have done that, because it doesn't tell you how much fluid is. You can have 4+ and just in the ankles, and it's just 5 pounds fluid overload if the patient is ambulatory and expresses there, or it has some stasis, or it could have 1+, it's in the belly, and the patient has 20 pounds fluid overload. So I rather look at the segments of the body that I see at the edema, and for each I give a plus, and then I multiply by 5 to give the total pounds for somebody who's got is about 70 kilos. If they're about 100 kilos, I multiply by 7. If it's more of a 50 kilo kind of person, I multiply by 3. I have a whole handout that I wrote for our house staff. I'll be happy to share that with you. And it doesn't have to be Sorescu method. I don't care what method you use to semi-quantify, but try something that will allow you and you learn in your way. This is just a starting point, and then you can adjust it. Because what? You see the patient for 5 days in the hospital, we have the documentation, you see how much they lost, and you can make your own idea. Oh, that works or it didn't work, or that kind of stuff, okay? But that's 1+ pedal edema up at the ankle. If it goes to mid-shin, the volume, then it's 2+ up to the knee, 3+ is thigh edema, 4+ is sacral or abdominal edema, or early satiety, another plus. And if you have shortness of breath, pleural effusion, anything like that, it's another plus. Add the pluses, multiply by 5. That's your estimate about the dry weight. It's a good starter point. It's not absolute, but it's better than just look at the patient and say, well, I don't know, I can't assess it. Okay. And one more thing before I go any further, jugular venous assessment for the house staff. Forget about everything they ever taught you how to and train you how to do it. It's wrong. Okay? Absolutely wrong. And I will tell you why. The IJ goes from here to here, goes from the little foramen that we have here under the skull, in a trajectory that crosses the sternocleidomastoidal muscle to the suprasternal notch. That's where it drains. So they told you, well, you go here, then you start to look up and gradually see where it stops, particularly stops in the front of the sternocleidomastoidal muscle. And I would beg you to tell me that a muscle that is this thick, about 100 times more powerful, you can see a jugular venous pressure behind it that's with a vein that's extremely thin, no matter what's the pressure. So that's why we all start to kind of hallucinate, thinking, oh, it's around here, it's around here. No, it's not. When I hear 6, 8, 10, I said, hey, have fun. Really, nobody can ever agree on that number because you're not seeing anything. You think you are seeing. You may see the carotid pulse. So I don't even dare to look at the vein in where I have my muscle. I'm looking straight behind the earlobe. Forget about looking from bottom to top. Just look straight to the top. Make sure the patient head is relaxed on the head of the pillow, about 45 degrees. If you see pulsation there, because there is no carotid has stopped a long time ago in the carotid triangle, then that's the JVP that's up is the earlobe, and that's the one that I'm going to diurese. That's high. Right there, pressure is 20. I have data is going to cause renal failure and neurohormone activation. That's it. If I see it anywhere lower than that, I'm going to ignore it. It's useless. Nobody says you can diurese. We don't know. What, 6 or 8? Does that mean volume is up? I don't know. Plus, I can tell you don't see it in front of the muscle. You may see the EJ or you may see the carotid. So ignore all. We used to do that because we had to do it. You know, we didn't have anything else back then 50 years ago. And then people keep publishing textbooks. They just copy and cat, you know, what they learn. And there's no, but I don't understand why we're doing that. All right. And then the second thing that I would like to challenge anybody in this audience, or anybody anywhere, severe TR and assessment of IJ. Okay, I hear from the house staff, and we need to stop teaching them that oh, if you have severe TR, you can't assess the IJ. It's just up anyway. That is wrong statement because the hemodynamics states what the severe TR does. It's a gift for us to see it easier. That's it. Okay, so we can see actually the IJ pulsations very well in somebody with severe TR. It's not that we should ignore it. It's increasing the sensitivity of your test. And if I see that IJ up to the earlobe, the column, which is the RA pressure of 20, I don't care what's the TR. You know, it could be severe, it could be mild. That is high elevated RA pressure. I'm going to treat it with or without TR. And for me, that makes it easier so I can assess it. So we don't, you know, we don't miss it. So yes, I would say if the patient has severe TR, that's great. It's easier for me to see it or not see it and diurese versus not diurese. So we need to stop teaching the house staff. Somebody with severe TR, you cannot assess the RA pressure. As a matter of fact, it's way easier, and it's a gift from God. Finally, we can see. All right. So I hope, and if anybody has other opinion, I'll be happy to be challenged. Okay? But it's just physics. All right. So anybody with a BNP of 1,000, think hemoglobin A1C of 13. You can't say, oh, it's chronic, it's stable. Okay. When I hear that, oh, okay. So if you see hemoglobin A1C of 13, you just say chronic stable, and you don't think diabetes has been poorly controlled, and we got to do something about that. You know, low sodium, we know is bad, less than 130. RA pressure, these are other things that tells us this is chronic volume overload. Don't ignore, counter what you think is your volume asset. Go back to the patient, all right? So let's do some more cases. I show you a simple one. Diurese or not diurese, low dose versus high dose. Now let's go to more complicated patients. I'm going to present first a couple of them that are advanced, or more advanced, or actually the usual patients that you see on 41 or on 61, that unfortunately they have a lot of volume. You try to diurese them, their kidney fails, and then what to do next. And this is a patient like that. This is a 66 years old, EF is 15%, mild to moderate RV dysfunction. You see, I'm going to present to you things that actually matter from the echo report, okay, that actually we should describe to you as cardiologists in the report. And I can show it to you that you don't have to be a cardiologist to manage the patient just like I manage using the same information I have. So EF 15%, mild moderate RV dysfunction. What does that tell us? This is a patient who has horrible LV dysfunction, but it's not so advanced that the RV is dead. And then there's some hope I can do something for this patient. All right. Gained 15 pounds. It's got a borderline blood pressure 90/60. It's on good medicine, Metoprolol XL 100. Receives 200 of IV of furosemide. Unfortunately, the urine output is dismal, and next day creatinine increases from 1.5 to 0.2. Does it sound familiar? All the time. What do you do with this patient? Clears volume overloaded. It's lukewarm. I love that when I hear from the house staff. Lukewarm, obvious, is a southern expression. That means I can't commit myself. Is it warm or cold? It's neither one or another. I call that mixed. That means it's probably warm central and cold peripheral. And that's a sign of low cardiac output, okay? Or a sign of increased vasoconstriction, and that means things are not good. If they're usually people agree when everybody's super warm. People usually agree when they're super cold, but it's this lukewarm that makes it complicated. Okay, all right. So when I hear lukewarm, for me, okay, it's got low cardiac output. All right. So 3+ edema, JVP 16 centimeter or JVP to the earlobe. That's more meaningful clinically. Dilated IVC on echo. Always look for that. It tells you have chronic elevated artery pressure over 20 millimeters mercury, probably. BNP 1500. So what do you do next? Now you got to become Sorescu on this patient. Let's see how would Sorescu do it. Metolazone 5, you add metolazone to 200 basis. Why? The patient has cardiorenal syndrome. You got more volume up. I'm gonna be brave. I'm not gonna be afraid of this creatinine increase from 1.5 to 2.2. And we just need more diuretic. And the answer is absolutely not. 200, it's a good test dose. It should have had a nice response, and creatinine should have not been worse. Now, if it didn't have enough response, but the creatinine is stable, then yes, the answer is yes. Maybe you just need to add another agent. But not if the creatinine bumped not just 1.5 to 1.6. I'm talking about from 1.5 to 2.2. The worst you can do is just directly diuresis. Something is not right there. Okay? So no, I don't like that. Hold the diuretics. That's the nice doctor. There's nothing wrong, not to harm until you figure out what's going on. I wouldn't have a problem with that, except the patient sounds sick, sounds like we got to do something about it. And that makes us, okay, what do you do next? Hold beta blocker. You know what? It's been on a good regimen as outpatient, but maybe for the EF15 and heart failure decompensate, maybe it's just too high dose of beta blocker. And there's nothing wrong. This is a step up from holding the diuretic and understanding what's going on. If you pick that one, I think we're doing better. But there are always better options, right? All right? Start the butyramine and hold diuretic. And this is what we do. There is no shame or worry starting the butyramine, a low dose, 5 mics. By the way, 2.5 doesn't do anything. Please, if you write the protocol, just do the whole thing and change it to 5. 2.5 doesn't. So either you give or don't. I'm not saying you should give 10 or 20. I'm saying it 5. Okay? So that's that. If you activate our protocol, it just goes straight to 2.5 by default. All right? And but also, if you start the butyramine, make sure you do hold the beta blocker. All right. So what I think happens right now, this patient being volume overloaded, function on the wrong side of the Starling curve, that by itself the volume is dropping more the cardiac output, and with the beta blocker is just not tolerated. This is a good cause to hold the beta blocker and add the butyramine. At this point, try to override that. I get more kidney perfusion, temporary, and it doesn't mean we're not going to put it back once we are done with, getting the new volemic. Okay, but that's important. And then start the butyramine, hold beta blocker, and give metolazone 5 and IV furosemide. Probably because patient still needs to diurese, I'll add the butyramine. I may wait maybe a couple of hours, let it kick in, and some of the beta blocker goes away, and then I can add these 2 agents and use it like you would have done it anyway if you were to ignore the creatinine's increase. But that's what the creatinine increase. And again, this provides nothing else going on. We think this is pure acute on chronic heart failure, no other comorbid illness is going on. All right? So it can go stepwise. It can be, a good doctor, or actually first one is not a good doctor. Everybody else is a good doctor if you have the options, but you can get better and better at it by thinking it through what's happening based on the echo report. Okay? So how about some Miranon? That's okay. Some people just use inotrope, and my only catch with how you pick Miranon versus the butyramine, Miranon is also a vasodilator, and when I have this soft blood pressure, you never know, is it just, in these patients we like more the butyramine. Also, you don't know, it could be a mixed picture. Something else could be vasodilated. The patient had Miranon, the next thing they'll be hypotensive. So not reduce blood pressure. I would probably do it with somebody 100/70, a MAP at least 90. That's not the wrong choice. But again, because I think I feel comfortable, I can even diurese on top of those inotropes. But just going through that. All right, is this useful? All right. Or I made it too complicated. All right, so the purpose of this is when you try, basically it's a bit of an enigma. When you look at somebody who's got AKI and you try to diurese, you know you need to, but it's got heart failure. And for me, there's always a blockage somewhere. So I'm thinking, okay, which one is the culprit here? I got heart, lungs, and kidneys, and might be some other illness. That's it. So heart, is it the right, the left side of the heart is a problem? So I look at the left. What's the EF? 15. Well, yeah, that might be a problem. All right. What if the EF is 55? I look at the right. What is the RV function? If it's mild and EF is 55, mild RV dysfunction, or EF is 45, mild RV dysfunction, patient has AKI. Whatever is going on has nothing to do with the heart. This is not heart failure related AKI. Okay, it's possible that it's heart. So I look outside that because the LV and RV function is not bad enough to justify what's happening. Okay, so you got to take, and of course, if they have severe AS or severe MR, you can have actually somebody with normal, you have severe MR. If the RV is also not good, then they can have low output in heart failure causing that. But again, echo can help you a lot, but just make sure you look both on the left or right and think, does that justify why the kidney is not doing good? That's all. And then if the heart is okay, then I will look outside the heart, and I'm going to show you some examples of that. All right, so this patient has a MAP of 70. Anyway, we do that. This will be a, this will be acute on chronic, more of an acute cardiorenal syndrome is combined with the chronic. And again, progressive heart failure, acute on chronic, that causes the acute kidney injury. So this is the cardiologist, the heart failure guys, or any internist can treat it if you actually take advantage of the echo. All right. What were the mechanisms here in my mind? So I go to bedside, I actually think to this potential mechanism. And this patient, like I show you, if it's just heart failure, the kidneys are vasoconstricted. They have a diuretic-induced normal activation, because I know I diuresed and the patient got worse. And it got also renal vein hypertension, because JVP is up to the earlobe. And I have probably some low cardiac output. That's the lukewarm in somebody with the metabolic cell that's 100 when they're near 15. Okay? So those are the mechanisms. Now, I don't think the patient is intravascular depleted. You can check orthostatic. If they're not orthostatic, they don't have that. And I don't suspect any other things. All right? So how about this one? You have 15%. This time has moderate severe RV dysfunction. All right? Gained 25 pounds. Blood pressure is 100/74. Is on metoprolol 50. Again, creatinine bumps from 1.5 to 2.5. Your NAP is low. So cold and wet. This time, everybody agrees the patient's cold. Obviously, you'll have to use diuretic. But remember, just using the diuretic without holding the beta blocker is not going to do anything. Okay? But this particular patient, look at the blood pressure. It's 100/74. We also have high mean arterial pressure, high systemic vascular resistance. So we like to vasodilate a little bit. Okay? I don't have evidence-based medicine for that. But I think everybody will agree that's what we do until we get more. Okay? And that's what we do. And most of the time it works. And this is a patient with truly advanced heart failure, needs to be called in by heart failure specialists to assess for advanced heart failure therapy. Often we swan these patients in the hospital to get a better assessment after their euvolemic. This is a sick patient. And it's the point was for you to recognize it. Again, looking at the echo. Now, unfortunately, we get often numb because these patients are also frequent flyers, right? So they come in, you just do your 40 IV laser, 80 IV. The patient says, I feel fine, send them home. Then they come again, and then they come again, and then the cycle repeats 3-4 times, and eventually rescue gets involved when the creatinine is 4. And my answer to you is too late, all right? Don't do that, because this patient, I can't help it once the creatinine goes way higher than 2. I can help them if they're 2.5 or less, or in general, but not if it's too late. So don't wait for that. So if you see already a couple of bounces back, just call me before that happens, or even once bounce back with that echo, all right? That's where we can help them. All right, so this is a patient who's really advanced heart failure, needs a new heart, right, or a VAD. Okay, and again, all of the above mechanisms apply. Okay, and this particular patient, because it had a higher MAP, we can go with Mirlinon here, and then add metolazone Lasix if you like to. All right. Now, how about this one? Okay, so now we're going to go through a little mysteries. 3 more cases that affect everything, and I'll be done. EF 4550, moderate severe RV dysfunction. All right, 35 pounds. High blood pressure on metoprolol XL. The culprit here is the RV, it's not the LV. This patient has obesity, OSA, that's the problem, okay? So creatinine went from 1.8 to 2.4. So for this patient, actually, I rather start the dobutamine, but it's one more catch. Sodium is 120. So often people ask, well, what do you consider tolvaptan? Sodium less than 125 with massive volume overload, you need to diurese the patient. And they fail the 1 liter fluid restriction. This is absolute indication for tolvaptan. Be cautious because that pill costs about $500 to $700, one pill. Okay, so we don't do this as outpatient. It's not cost effective, but for a day or two until. Why is the sodium down? Remember, the diuretic activates more vasopressin. So particularly if I need to diurese more, I know next day the sodium is going to get worse. And then they get delirious, we get into other trouble. So it's better to hit. And I'll choose tolvaptan with the furosemide. In general, I wouldn't add also the metolazone unless the patient is extremely sick or in CCU. Because remember, adding metolazone is kind of the diuretic, that activates more vasopressin and more hyponatremia. So that's one indication for that. And, again, this is a patient who's got horrible right side heart failure and kidney dysfunction from it. We actually have some data telling you when to add the second agent, the cetazolamide or the metolazone. And because you'll say, okay, how do I know when Sorescu wants to add the metolazone, right? Because it looks like he's adding it on everybody. Well, here's how you know. You can actually send a serum sodium, urine sodium, spot sodium, after you diurese somebody. Because if they pee a lot, if the sodium is high, you'll see the urine output will be a lot. And that means their sodium should be very high in the urine. That means you did meaningful diuresis. You don't need to add a second agent. But if you diurese somebody and the urine sodium is less than 10 on the urine, and you'll see there'll be also a little urine out because no sodium came out, then those are the patients who actually have data like this particular study published over 40 years ago, 30 years ago, showing that if you add the second agent where you use acetazolamide or use the distal collecting tubular channel blocker like metolazone or chlorothiazide, it will do the job. So you could do that. Or you can just look at urine output. I use 80 of furosemide, I use 200, I expected 3 liters of urine output, only 500 happened. That means the urine sodium probably is going to be low. If you're in doubt, you can check it, all right? Unless they have ATN from interstitial nephritis, from bacterium or some other issues, the urine sodium is not going to be high, it will be low, all right, if the total urine output is low. So that's one way of doing it. And nephrologists, know this. Everybody, this has been studied, and and I'm going to go. This is just a summary for those who want this. Just summarize what I just said. I want to do one more case, and then we're done. 38 years old, EF 25%, normal RV function, comes with acute decompensated heart failure, fluid overload, is on good medicines for diabetes, high blood pressure, and everything else. Carvedilol. You give the 200 furosemide, and the creatinine goes up from 1.6 to 2.4. Very familiar, all right? And then patient's warm and wet. It's got a lot of fluid on board, all right? And what do you notice here? We need to figure out why they get AKI, all right? And we have absolutely no explanation, because if you call me, I look at the echo and I'll say, okay, EF is 25%. So about half of my patients haven't been in the hospital for 10 years, all right? If they do the right thing. It's just an EF of 25%. They are chronic. It's been for years. Unless it's acute, that's a different story. It does not justify why you get AKI from somebody who's volume overloaded. If the RV is normal, and no major valvular disease, something is not right. So I go back and ask the patient, and I see they are looking pain, and I start to touch the joint, or I check for post-vital residual if they are, elderly, particular men, if they may have a urinary. In other words, something else is hurting the kidney, and of course, is going to block and will aggravate the response from the diuretic. This is where comorbid illnesses come into place, and what I would do, left knee was painful, I cannot move it. It clear is not much heart failure because BMP is only 700. I hold the diuretic and I treat the other condition first. You'll see me treating very aggressive the gout or putting a folate if I need, if there's a post-vital residue over 250 or 300. I do that first. Next day I come and I diurese after I see the creatinine is improving. But be aware of that. Don't do both. That's why we run into trouble. When you call me, I look at the echo and I say, this is not from the heart. And you'll see me asking you, oh, can you please check this and that? And, you get upset with me. Why are you asking me to be an internist? I said, well, unfortunately, that's what matters, because I know it's not the heart here, okay? If it's the heart, I'll add the inhibitors, we add together the vasodilators, but it's not the heart. I know when it's the heart, and I know when it's not the heart. That's all. And another thing that's important here, anemia, all right? It's finally, the heart failure guidelines have been updated, both systolic and diastolic heart failure. Please do not ignore a hemoglobin of 8 of somebody with acute heart failure in the hospital, because that's part of their heart failure progression. We know that if you get that better, if you treat iron deficiency anemia, they will get better. So, house staff, oh, it's chronic, don't worry about it. It says, yes, I'm worried about it. And if I saw it chronic as outpatient patients asymptomatic, then I'll refer to hematologists, let them handle it. But if I see the patients in the hospital with heart failure, with volume overload, then that's part of that. Because low oxygen delivery is the ultimate stimulus for neurohormone activation and keeps the patient heart failure. So we have evidence now. Please be more aggressive. Do some basic search. If you find the culprit, iron deficient or whatever, give them isochronous IV in the hospital. It makes a difference. Okay? All right. So this particular patient had all the three above in terms of having AKI, but also has some kind of SIR syndrome from the gout attack, which is important. Vasodilated periphery, and yet another stimulus to vasoconstrict the kidneys. Okay? And then the last but not least, here I just show you the data that indeed TNF-alpha and IL-6 do that. Last but not least, 78 years old, you have 35%, Mild RV dysfunction, acute decompensated heart failure. See, LV, RV, not impressed. It's got AKI again, although it's extremely volume overloaded. Creatinine goes from 1.5 to 0.3. All right? BNP is 1500. So it has heart failure. It's more chronic heart failure, acute on chronic. What do you do with the diuretics? Okay? All right? And the answer is, yep, it's 35. Something else is going on. That's the answer. Okay? Something else. He's a man. Any man over 60, they have the right to have BPH and have urinary obstruction. And it doesn't have to be hydronephrosis. If you actually talk to urology and nephrology, they'll tell you it means nothing. You know, just because you don't see hydronephrosis on the renal scan, it does not mean they're not suffering from urinary obstruction. They can cause AKI, particularly, you know, the pressure is up in the urinary tubules, and at the same time we try to pressure diuresis. That's what decompensates and makes it worse. So yes, go ahead and put the Foley, work on Flomax or whatever else they need to work, or treat their UTI. That will make the difference. And that's how I found it. Okay? Go backwards and sort it out. It's not the heart. Okay? That's for sure. There are other things that are there. But if you have a patient who is really cor pulmonale, I mean, who hasn't managed this and found they're extremely difficult to manage, they're easy to get kidney failure, right? And then we have to step back. They're also the most massive volume overloaded. And often they are HOMO 2, and they have hypercapnia. And then when you start to diurese them, their bicarb goes to 40. They get sleepy. It may aggravate hypercapnia. How do you treat those patients? Okay? And the bottom line is you treat with everything. All right? If I see the RV is at least moderate, all right, I'm going to support the RV. I don't care what it is, because I don't want to take any more chance for the kidney to get worse until I figure what's going with the lung. Remember, volume overload will aggravate your hypoxia or hypercapnia too, the hypoventilation and everything. So that should be part of the therapy. And if bicarb gets anywhere close to 40, that's my, you know, it doesn't have to be 40, maybe 35, it's your threshold. But think this way, I can tell you in my experience, 15 years, if it hits 40, everybody's got hypercapnia from metabolic alkalosis. So if you like more 35, that's fine. But 35 or higher, add the acetazolamide. And don't add just one dose. As long as you want to intensely diurese somebody, you have to continue to use the acetazolamide, because the loop diuretic will just aggravate that to reabsorb more from proximal tubule, and you see BUN and bicarb going up. And fix their potassium. The potassium exchange for H plus in the tubule. So you really want somebody with metabolic alkalosis to have a potassium higher than 4, so you can get your alkalis down. It's very important. Okay? So when I see these patients, I start thinking cor pulmonale, hypoxia, okay, it's not necessarily the heart, it's the lung, it's the pulmonary cardiorenal syndrome. It's not just that. And I need to focus on that. And yes, I do need to remove the volume to help the lung get them back to the baseline. If they need to go on the vent, because I don't have room for my metabolic alkalosis and diuresis, they need ultrafiltration, so be it. If indeed this is a patient that we think will rescue, it's not a hospice candidate or advanced palliative care services. But these are patients who, yes, are very sick and very poor prognosis, and we should think all the time. So this is more of a pulmonary cardiorenal syndrome. And we have data actually showing many, over 20 to 50 years ago, in 78 published, hypoxia per se, nothing else, activates chemoreceptors to release ADH, and then the chemo would absorb water. So that's why patients with right side heart cor pulmonale are the most edematous patient. They actually reabsorb, their vasopressin gets activated before the other neurohormones, just from chronic hypoxia. So that's out of proportion to actually the angiotensin 2 or the sodium. All right. So hypoxia per se, chronic. You'll see these are very easy to actually retain fluid and aggravates there, but also hypercapnia will do the same thing. All right. And I think I'm going to stop here. All right, because I see John's becoming. I appreciate your patience, but I thought reviewing some cases may help to make a better point here. All right. All right. Thank you. Yeah. All right. Thank you. Sure.